Well, thank you very much for the kind invitation to speak at this interesting event. These are my declarations of interest. And in my presentation, I just thought I'd give you an outline of what I plan to talk about. I'm going to talk about the National Early Warning Score News and why we developed it, some of the key principles underpinning it, and then some of the ways in which you have to approach trying to get national adoption of a system across the entire healthcare system. And of course, the NHS is a useful experiment in that way. The NHS is the sole healthcare system for 70 million people in the United Kingdom, almost 20 million hospital episodes in that single system with a single data set. So this was a fantastic opportunity to try and transform the way we manage acute deterioration in hospitals. Now, this all began just before the Olympic Games in London in 2012. So this has got quite a long history. Actually, we launched News on the same day as the opening ceremony at Olympic Games, so there wasn't great planning by the NHS, but which is not untypical. But the statement in the launch by the Royal College of Physicians and the NHS was that this system might be able to save 6,000 lives per year. That was actually a very conservative assessment based on what was then thought to be about 12,000 avoidable deaths per year in hospitals. I personally think the number's much bigger than that because many of the deaths that take place are not recorded as potentially avoidable when indeed they are, and I'll come back to that in a moment. But I spent some time reflecting on what was nearly 15 years ago now when we first started this, thinking about the kind of things that went through our head when we were trying to develop a system that would be rolled out nationally. We recognized we needed to have a standardized system that everybody used across the health service. In hospitals in the NHS at the time, there were often different early warning scores in every single area of the hospital. The intensive care would be using one for their outreach teams. There'd be a different one on the surgical ward. And doctors didn't know what the individual scores meant when they were called about a patient's state of deterioration. And this led to huge confusion. We also wanted to try and standardize the detection and the response to the patient. And the ultimate aim was to develop a common language that would be used across the health service system. And we've succeeded in that. If you were to go into an NHS hospital today, the junior doctors will be walking around talking about news and who's in resus, who's down in the emergency department, who's on ward 6, and various problem patients with the news score very prominent in terms of the level of illness severity. Another important aspect of this, it will become less important as we move towards widespread electronic health record systems, but system-wide unitary documentation. We had a system whereby almost on every single area of the hospital, they had different ways of recording information. They had different charts at the end of the beds of these patients. And that lost the opportunity for any person in the system being able to recognize deterioration on a patient's chart. And finally, and it hasn't been emphasized enough today, and I hope it will be as we go through, the importance of education, training, and accreditation in response. You can't train a system unless everybody's using the same system. And we've been able in the NHS to accredit as part of now mandatory training in the NHS that people training this and refreshing this every year. So the vision was a common language. Everybody across the system knows what it meant if somebody called and said, my patient has a news score of 7. We almost didn't need any more information. We knew that that patient needed an emergency and rapid response. And this was designed to happen across the entire system, not only focusing on hospitals and certainly not only focusing on intensive care, where only 1% of the hospital activity takes place, but actually also focusing on primary care. How do GPs triage emergency transfer to hospitals? How do community care facilities emergency triage? How do ambulances understand who to prioritize when they have multiple calls? That has changed because of this kind of very simple system. So the levers for change were really the number of basic assessment and early warning scores being used across the system nationwide was unacceptable. There was no justification for the continued use of multiple different systems to assess illness severity. And when we produced this report, I was asked by the then president of the Royal College, what single thing would we like to take forward? And at the time I said, we need to take forward the early warning score. We needed to develop a system across the whole NHS that everybody understood and everybody could respond to. Now, of course, this is well known to this audience, but I can't emphasize enough what a battle it was trying to get the concept of standardization across the NHS. Often, individuals within different hospitals had developed their own early warning scores, sometimes eponymous early warning scores, and they didn't want to see it changed for a national system. They argued that maybe theirs was a marginally better than news, or potentially better than news. What we argued was standardization, where everybody understands what the score means and how to respond to the score and is educated in the system, will be much more powerful than a marginal difference in the precision of an individual score. So the key principle was standardization. And this was beautifully emphasized by Bruce Keogh, who was then the medical director of the whole NHS. And Bruce said this in the opening remarks for the news when it was launched in 2012. Systems operating with similar levels of risk use universal means of communication to reduce the chance of system failure. Air traffic control systems across the world adhere to common standards and language to prevent disasters. And it should be the same in hospitals. Imagine what would happen if each airport had its own way of working and its own way of dealing with a crisis. They don't, they all operate in the same way. So when we set out, what we wanted to do was to really focus on the triad that determines clinical outcomes, which has been beautifully discussed by previous speakers. The early detection of clinical deterioration and the speed of the response to that change in the patient's status, and importantly, the competency of the responders, the ability of those responders to turn the situation around. And then on top of that, and this will become less relevant as we go to continuous monitoring, but it's still relevant in many systems today, the frequency of monitoring. If somebody has a certain level of illness, how often should you monitor them? Trying to get that standardized across the system, because in most systems, the default was monitoring not enough. And that was something we wanted to change. And then finally, what is the most appropriate setting for acute ongoing care? Is the score sufficient to warrant consideration for transfer to a higher dependency area, or indeed to a coronary care? And likewise, is it sufficiently improved to think about step down of care? So this kind of thinking really got the whole system excited about the huge potential change they could make and the efficiencies, not the cost, but the efficiencies by driving quality and consistency of care. But I emphasize, again, and I think this is going to become a very important consideration when we start thinking about AI, the importance of simplicity in the healthcare system. It's a complex system. And the things that are done well are the simple things. And in fact, I love this quote from Da Vinci, perhaps the greatest innovator of all. Simplicity is the ultimate sophistication. But simplicity is incredibly difficult, as I discovered when I was leading this charge. when you're dealing with doctors, because doctors think they're sophisticated, and they don't like simplicity because it undermines their sense of sophistication. So when you tell them that Da Vinci said this, it's the ultimate sophistication, it tends to improve the situation. So we wanted to base the assessment on physiology. And I know that if you could put 1,000 parameters into the assessment, that clearly might make it more effective. But we don't have 1,000 parameters when somebody's lying on the curbside in the street when the ambulance arrives. We don't have lactates. We don't have blood tests. We don't have 1,000 parameters when somebody goes to the general practitioner for the first time and says, I'm not feeling well. What we have is physiology. And that physiology, human physiology, as we'll see, is enormously powerful at giving you the answers about how ill a patient is. So news is different because we wanted it to be simple and we wanted it to be practical in every single setting and also deliverable by even the most basic level of training within the healthcare system. We did not want additional parameters such as blood tests or specialized equipment, as this would limit widespread use. In fact, even in the early days, back in 2010, we were having discussions at that time about whether to include oxygen saturations because that wasn't yet regular across the whole healthcare system. I'm glad we did. So we wanted the result to be instantaneous, not require calculation or compute. And we wanted this to drive immediate decision making. And that's why we focused on the basic physiological parameters. Yes, they're well aware, you're well aware of all of them. And we also thought about the chart. And now I realize charts are now disappearing as we move towards electronic health record systems. But the principle underpinning this chart was incredibly important, and the nurses love it. The nurses loved the idea that there was a visual way of observing deterioration, not just represented by a number, but by showing a trend in the patient's change. When we originally launched the chart, Professor De Vita mentioned red, amber, green. Actually, we made the same mistake because, of course, there are people in the healthcare system that are red, green, colorblind. And so this is the updated chart, which contains this more amber color, more sort of colors which apparently work with the red-green colorblind. The other thing about news is because it was going to be used across the whole system, we wanted to use the score to provide simple messaging to the system about the levels of escalation that would be appropriate. So a score less than 5 if you're in hospital, generally ward-based care, emergency ambulance not usually required. Occasionally, patients score highly on a single parameter. That's unusual because physiology is coordinated, and that's why aggregated scores are so powerful, because things change in parallel. But sometimes you do see a single high score of 3 or more. And we said under those circumstances, get the local ward-based doctor to have a look at the patient and determine why that individual score is abnormal. But it was really the score above 5, which our data was telling us was a very important threshold for concern. And in addition, because we were trying to stop multiple scores being developed for multiple conditions, as we heard earlier from Jean about having scores for everything, it just doesn't work. We wanted to try and show that news would work for sepsis as well, as I'll show you in a moment. And lastly, of course, if the score was 7 or more, this was a measure of serious concern. And if you were in the community, this would mandate the ambulance to do a blue light emergency transfer to hospital. So the ambulance services love this because it gives them the ability to triage patients based simply on patient physiology. In the early days, I remember having lots of discussions with experts from the RRS field about the possibility of simplifying it even further using single high scores versus aggregate scores. And we resisted that because we could see that aggregate scores work. Actually, this is a chart from University College Hospital in the very early days of news. And it's a beautiful illustration of the coordination. This was a patient on the ward, one of my patients actually, who developed a urinary tract infection. You can see here an increase in the temperature, is paralleled by increases in the respiratory rate, paralleled by increases in the heart rate. These are only small increases in of themselves, each scoring 1 or 2. But obviously the aggregation of that coordinated physiological response give rise to the highest score. And it's a very, very powerful and sensitive way of detecting deterioration. And obviously, as we move towards AI and digital monitoring, the ability to be able to monitor these subtle but very powerful changes in physiology will undoubtedly give opportunities for earlier detection. But having mentioned the importance of these scores, I think it's also important to recognize that there's something else that sometimes matters, and that is, experienced doctors doing the rounds, as we all do, often can just have a sixth sense about something not being right. And we made it very clear that concern about a patient's clinical condition should always override news if the attending healthcare professional considers it necessary to escalate care. This is no scoring system, whether AI-driven or not, will be a substitute for clinical experience. And people say to me that, AI will replace doctors, and my response to that is always, AI will not replace doctors. AI will only replace doctors who don't use AI. And the point is, we will have to use AI in clinical practice, and we should be using it, but it won't replace you all. It will be something that we can use as a tool to augment and enhance our ability to deliver effective and efficient medicine. So news and any other warning score can never be a substitute for clinical experience. And importantly, this must never be medicine by numbers. It is an aid to medicine, not a substitute for clinical acumen and clinical skill. And news doesn't replace disease-specific validated systems either. So it can be used alongside, for example, things like Glasgow Coma Scale, which obviously gives a much more sophisticated assessment of somebody's conscious level. Of course, today we'll talk a lot about validation and the challenges of validation. In the early days of developing news, we were very grateful to Gary Smith and colleagues down in Portsmouth, who had one of these original, very large-scale databases collected on electronic systems that we're able to go back and interrogate to see how well news performed against what was at the time 33, that tells a story in itself, 33 early warning systems being used across hospitals, many of them used in the same hospital, multiple systems. And we were pleased at the end of it to see that news did pretty well. In fact, it was the best of the systems using this particular measure, which was an area under the curve, operating receiver curve, which may not be perfect. And I'll come back to that. Now, there was always pressure to update news. Once we'd launched it, there were multiple grumblings from specialist medical societies, which must always be resisted because they are usually focused on self-interest rather than the wider interest of the healthcare system. But one did lobby very hard to, because they were concerned about some of the scoring around oxygen and oxygen saturations and oxygen supplementation in patients with type 2 respiratory failure. So we did make a change there. And the update to news was relatively minor. We changed some things on the observation chart. You've got to have a post-launch surveillance. It's very important. It's very important to see how people use it and we had a frequently asked questions and we had a feedback to allow us to change things. We had to change the red, amber, green, the oxygen saturations I mentioned. But the other important change was we had a score of 3, which is the highest score for patients with impaired conscious level, but also the suggestion that we include new confusion, which I think was a really important one, because as we know, particularly in older patients, presentation of urinary tract infection may simply be somebody suddenly becoming confused. And so new confusion is often a very serious clinical sign of clinical deterioration, and we included that. And finally, we managed to fight off the arguments about introducing a special chart for sepsis and pointed out that news worked pretty well in sepsis. So this then went out with a launch in 2017. There were charts around the NHS pointing out that we wanted patients who had new confusion to score 3 because this was an important clinical sign of deterioration. And actually that in itself is an education point that was quite powerful across the system. And then again, a new NHS alert was around sepsis, which said that if you scored 5 or more, it doesn't mean it's sepsis, obviously, but think sepsis. Think, could this be sepsis? And that has had a huge impact on increasing the awareness of sepsis, because sepsis, of course, as we know, can present in a whole manifest different ways, none of which are often very specific. And when we looked at the power of the threshold of 5 for this, it really was quite impressive. This is just based on simple physiology, that if your score was 5 to 6, your likelihood of being admitted to ITU or mortality from sepsis was 3-fold higher than a score below 5. So this was quite a powerful threshold for predicting deterioration in patients who had imminent sepsis or sepsis. But it isn't just sepsis, and I think this point was made earlier by Jean, that if you have a single score of physiology and physiological deterioration, it picks up physiological deterioration, whatever the cause, whether it's sepsis, whether it's hemorrhage, whether it's infection that's not yet sepsis, etc., etc. And we can see this quite beautifully on this slide. And also what was important in this is that when we looked at the low scores, there was not any fatigue or over alert in these patients. It was really the high scores where we began to see the uptake in clinical deterioration. But our objective was to try and prevent those high scores developing by intervening at a much earlier stage. Something came to light later, which I think is a really, really important message that often doesn't get emphasized. When you move towards using these systems, and particularly as we move towards AI and digital systems, and becoming reliant on the system, the black box, to tell us a number that gives us an indication of how seriously ill a patient might be, there is a danger that we forget that there is a disease underlying the number. There is a condition underlying the number. And actually, in the emergency department, we can quite often in resuscitate a patient so their new score drops from 7 to 3. We rehydrated them, we give them some paracetamol to reduce their temperature. We managed to stabilize the patient very quickly, and their physiology improves. But that doesn't mean the disease has gone away, necessarily. And this has led to some disasters. It's led to, patients being transferred from one area and arriving in another with a new score that looks quite good, but nobody transferring the information that the new score wasn't good when the patient arrived in the hospital. And the only reason it looks good is we've done some initial remedial treatment, and this patient should be still considered potentially high risk. And that was a very, very important message and learning point across the system. But actually, our efforts to get widespread implementation have had a remarkable success. 98% of all acute hospitals in the NHS are now using news as an early warning score. And 100% of the ambulance service absolutely loves news because it's given them an objective way of communicating risk. And of course, we had to educate everybody. and we put out a whole series of resources from the Royal College of Physicians. And one of the most remarkable things for me was when we first launched the education platform, it was totally voluntary. And thousands of healthcare workers across the NHS, from all stages of whether it's down at the ward level, the senior level, in different areas of healthcare, voluntarily decided to train in news and that sent a message that they recognized this was an important system for their routine day-to-day work. So we now have over 100, there's millions of downloads of this now across the Royal College site. And let me just show you the training and education platform. This was developed, again, by a not-for-profit, completely done voluntarily initially because this was all very early. Eventually, it was picked up by the NHS. It's now part of mandatory training annually for all doctors in the NHS. The uptake by healthcare professionals was truly, truly remarkable. Now, at this date, it was 24. It's now over 500,000 NHS staff have been trained and are continuously trained in news. And the platform has now got 500,000 completed modules, 3,000 to 4,000 NHS staff complete training every month because of the repeat training requirement. And the completion rate, once you start this module, is 85%, which is the highest completion rate of any NHS training module. And there's also increased users from people working in different spheres like mental health, community care, primary care, equivalent to about 46,000 users. And most of the NHS trusts have now graduated this onto their local learning module for the NHS. And when we first launched the education and started capturing data, you can see here that early on, most of the people were working in acute hospitals who were training, and by 2021, half the people training were working in the community and in other disciplines in healthcare. So this has really now permeated the whole healthcare system. And the NHS continually pushes out resources for training across the country, including me, giving updates on a regular basis on the National Early Warning Score. They launched an app, which actually was reasonably popular, but actually, nowadays this is pretty much incorporated into electronic health record systems, and so this is not necessarily required, but is used by some of the people in general practice and in the community setting. As well as in England, where this originated, it's also been adopted, particularly with the help of Chris, across Wales and also across Scotland. And as I mentioned, there's total permeation into the ambulance system and hospital system, and increasing uptake in primary care, etc. Now, if we look at impact of news, there's definitely been more than just impact in terms of uptake. There's an increased focus on documentation. There is prompting service redesign. Somebody mentioned the cost of services. This has led to mandatory service redesign and the provision of 24/7 response teams across the NHS, which didn't exist. It's not totality yet across everywhere in the country, but it's getting there, which is a great improvement. And reports from the regions and our big databases are a 20% reduction in mortality since launch, which I think is consistent with what we've seen, we saw earlier from New South Wales following the introductions of these systems, and at least a 50% reduction in cardiac arrest across the entire healthcare system in our hospitals, and reduced length of stay, etc. I need to skip because of time, but I just wanted to show you this. This is one of the early adopters in the community. On the right, you see here, these are the sepsis rates in the west of England. These are mortality from sepsis. We have all this national data. This is the England average. They were already doing quite well. They implemented news in the community. This is not hospitals. This is saving lives in the community by early detection and response. They've now got the best outcome in the whole of the United Kingdom following the implementation of this system. Yet the final points I would make, and I'll have to finish quickly, I've just noticed we're nearly out of time, but we are quite lucky in that we have a system like NICE, which basically, if it gives endorsement to a specific system in the healthcare practice, that will then get adopted across the whole system because it's been evidence evaluated, and NICE basically promoted news across the entire healthcare system. We've now got news adopted into the final cycle of quality. In the NHS, we have quality standards which are audited across hospitals to make sure they maintain quality. It's a very competitive process to become a quality standard, but news is now an NHS quality of care standard. So they're now auditing the use, but also the response and the organization of systems for news. Final comment I'd make is that, it's not just about the implementation. It's also about the fact that it's driven up training. People now measure vital signs properly because they're required to record them, and the monitoring is also audited. And it's led to the development in the NHS now, and just launched, of a maternity early warning system and a pediatric early warning system. The reason we have two different ones there is they have different physiology, and therefore the scores are different. Quick comment to finish. I think AI and machine learning will undoubtedly change things, but actually tracking physiology will, I still think, be the fundamental basis of these systems, because it is remarkable how effective physiology is as a predictor of adverse outcome. So although you can add lots of other parameters, and I think continuous recording and trends are going to be important and add value, there's nothing better than the physiology. And NICE is, the government in the UK is already moving towards digitization by helping create standardization, HL7, and the FHIR compatibility and APIs, so that all of this can be embedded into the systems. So I was going to comment, but Dana will deal with this later about validation. My only comment about validation is this needs a lot of work in this area, and the only comment I would make about news in this particular validation is that it is pretty remarkable how well it did against an AI-based system, etc. So in conclusion, developing an EWS at the outset requires a clear understanding of when, where, and how you want to use it. It requires system-wide mandatory training and education. It requires professional and regulatory and government and health system-wide support to ensure implementation. I think digitization and integration into electronic health records can improve data capture and decision support. AI and machine learning will offer the opportunity for comprehensive use of large-scale data. But at the point of care, that data may not always be available in all settings, and the simplicity of these kinds of systems still needs to be maintained. The performance of news versus sophisticated AI and machine learning-based systems is quite remarkable when one considers its simplicity and utility in all healthcare settings, and it tells us a lot about the power of human physiology and its response to illness. News has led to major improvements in the recognition of acute illness severity and clinical deterioration in the NHS, and improvements in the accurate and complete recording of vital signs. There's no doubt that these systems improve patient outcomes, and agreed principles will be needed in future to define the most effective way of validating and regulating these systems, especially with increasing digitization and the use of AI and machine learning to drive decision support. But for the moment, I was pleased at least to have played a small part in helping develop news and ensuring at the time that the NHS was the first healthcare system in the world to have a system-wide common language for acute illness severity and clinical deterioration. Thank you very much.